today is Dr. Shivram Bhonagiri. He's a very experienced MD physician. The topic for him would be recent advances in management of diabetes mellitus. Can we have you, sir? Chairperson are Dr. Rajendra Joshi, sir, who's a senior physician, and Dr. Dinesh Lokhande, sir, who's a very senior chest physician, very well known. Dr. Rajendra Joshi, sir, and Dr. Dinesh Lokhande.
Dr. Shivram Bhonagiri is a senior physician, having 20 years of experience in medicine. Today, his topic is recent advances in management of diabetes. Over to you, sir.
Yeah, thank you, everybody. And I'm quite aware that the Don has spoken. Very few people are interested in what I'm going to say. Don has already floored everybody here. So I don't think that I try to make my lecture as less disappointing as possible. So we'll go to recent advances in diabetes mellitus. A lot keeps changing in diabetes, like in cardiac, as you know. So ADA, or American Diabetic Association 2019 is what they have given the management guidelines for the year 2019, and we'll quickly run through them before we run through the rest of the lecture. So what are the criteria for diagnosis of diabetes mellitus? Already reckoned up for practice is that if you have fasting sugar greater than 126 mg/% on 2 occasions, fasting means fasting of more than 8 hours, or a 2-hour postprandial glucose of more than 200, which is during a 75 gram glucose, which is also on 2 occasions, or an HbA1c of greater than 6.5. So these 3 things will tell you that there is a chance of a diabetes mellitus which you are looking at. Or there are symptoms of hyperglycemia and you do a random sugar and it's about 200. So that is definitely diabetes. So 2 abnormal results from the same sample or 2 samples on separate occasions are what will actually tell you the fasting and PP are more than normal and probably the patient has diabetes. So the other thing is, how do you nowadays, what happens is, you have a lot of patients coming to you and they will ask, do I have diabetes? My parents have diabetes. So how do you classify them, or whom do you test? So these are the criteria for those who have pre-diabetes or in children and adolescents who are overweight or obese. These really require to be tested early so that you can catch them early and they can have the treatment started or even the lifestyle modification done early. So those pre-diabetics children or children who are overweight and obese, who have a history in a mother of diabetes mellitus or whose mothers have gestational diabetes mellitus, they should be screened. Those who have family history of type 2 diabetes, they should be screened. Certain ethnicities like Asians, they should be screened more. Those who have signs of insulin resistance or conditions associated with it, like the acanthosis nigricans, the PCOD, should also be screened. So these are the ones whom you will test early. What is early? Generally you start at the age of puberty or little beyond puberty and start looking for signs of this in those who are overweight or obese. And those who had a small for a gestational birth weight, they also qualify for patients who require risk-based screening. The idea now is actually not to look at diabetes as only a disease of the sugar, but also that it encompasses a lot of other syndromes like the cardiac and the renal problems. Now, what is the criteria for pre-diabetes? Whom would you call that pre-diabetic? And he has to be more careful about his sugars. Those who have fasting sugar between 100 and 125, they should definitely be told that yes, there is a risk of diabetes and please be careful, lifestyle modification must be started immediately. 2-hour postprandial glucose during the 75 gram OGTT is 140 to 199. So as you saw, more than 200, definite diabetes, 140 to 199, please tell him there is a possibility you might develop diabetes. Don't tell him, previously you should have everybody 170, 180, you have diabetes. So be a little careful in telling them, tell them you have pre-diabetes, you can develop diabetes, so just be careful with it. HbA1c between 5.7 and 6.4. So these are the patients whom you should tell that there's a chance of getting diabetes in future. So whom do you screen? Do you screen everybody for this? You screen overweight definitely, you screen the obese, and or with the onset of puberty, or is when you screen these patients at the onset of puberty, like I already told you, or 10 years, whichever is earlier. And some people have very early puberty, so those people must be screened. If the tests are normal, in those who have chance of developing diabetes, please repeat every 3 years, or more frequently if they are getting obese or their BMI is increasing. Now, the important thing for most people here is gestational diabetes. I think a lot of gynecologists here. So gestational diabetes is something that all of us want to know what to do, and the incidence is definitely increasing by the day. So test for undiagnosed diabetes, that's the first prenatal visit for women with hypertension, dyslipidemia, acanthosis nigricans, or PCOD. So these are the patients whom you will test in the first visit itself. For the others, you test for GDM at 24 to 28 weeks in those who don't have DM and those who don't have the above mentioned conditions. So diagnosis of GDM is again something that's changing all the time. As you know, every year people are coming with new normals. So the main thing is whom to test, when to test, all these are always something that are keeping on changing and adding to our confusion. So there now ADA 2019 has said that there are two strategies. One is called a one-step strategy. So what do you do with one-step strategy? You perform a 75 gram OGTT with fasting 1 hour and 2 hour values. Fasting is 2 hours, 8 hours fasting overnight. So when you diagnose GDM, fasting DSL greater than 92. See, previously we had this 95 to 99 with the American, 92 to 95 with the European. So this all, now the ADA says fasting sugar more than 92, please stay in GDM. 1 hour PP sugar more than 180 or in GDM. 2 hour sugar more than 153. Now this is a very foxy thing, 153. I don't know how they got it. But anyway, it's there. So this is what is the recent thing, 2019. Or they say two-step strategy. Why the two-step strategy? In US and elsewhere, you don't have patients who can walk into your clinic every day. So here, a patient can not take an appointment, come to you anytime, say, check me up. There you require appointments, then you require screening. Even to do a blood test, you require to take appointment with a pathologist. So that makes things more and more difficult. So what they have done there is they have made it a two-step strategy. What you do is step one, if the patient has come to you without on non-fasting stage, so you give him 50 grams of glucose and tell him wait for 1 hour. After 1 hour, if sugar is greater than 135, say you have a chance of GDM. So then what you do is you have to go for the step 2. So what that does is that screens a lot of patients who you want to find out definitely if they have diabetes or not. You do the first step, non-fasting, less than 135, say okay, go home, you don't have GDM. Okay? If you are more than 135, say okay, you might have a chance of GDM, so let's test again. So then you go for step 2. So step 2, in a fasting state, you give him 100 grams of glucose. After that, you decide on whether he has GDM. So when we say he has GDM, fasting greater than 95. Why? Because now you've given 100 grams of glucose instead of the 75. The last one step is also 75 and 92. Now they have made fasting 95. 1 hour is more than 180. 2 hours is 155, which is 153. So very little tweaking they have done. What they have added actually is what is called as 3 hour. Now a lot of things is because of so many maternal fetal problems, now people are more and more careful. So they have done now 3 hours based on certain studies. They say greater than 140 still classifies in GDM. Okay. Now this treatment of GDM will not go into, because it's a rather exhaustive and big topic. Of course, the mainstay is, of course, as you know, metformin. Although it's not approved extensively used, and insulin is the mainstay of treatment. But what do you do if a gestational diabetes patient has delivered, and how do you follow her up? So these are again ADA recommendations, how do you follow up? Because most diabetes patients will keep coming to you after the delivery. So you are the first contact with the patient. So how do you follow up those patients? So those who are gestational diabetes and have delivered, these patients you test at 4 to 12 weeks postpartum using again the 75 gram oral OGTT and use the non-pregnancy values which we use otherwise patients who are not pregnant or normal patients. So use those criteria to diagnose diabetes mellitus, which already I have shown you 126 fasting and the 200 pp. So women with GDM should be tested every 3 years for diabetes mellitus or pre-diabetes. So those who are negative, still keep testing them every 3 years to look for DM or for pre-diabetes. And if pre-diabetes is detected in a patient with a history of GDM, that is, they fall in that pre-diabetes criteria which I showed you, then start lifestyle intervention, or sometimes even metformin now is recommended so that to prevent diabetes. So metformin not used in this case to actually treat diabetes, but to prevent diabetes in pre-diabetic who had history of GDM. Now, these are what has changed in 2019. Now we are not looking at only sugar values whenever you are going to treat any patient of diabetes. We are going to identify what are called the goals of care. So what are the goals of care? You have to prevent complications. So most important thing when you are looking at diabetes is don't look at only sugar values. Please keep checking his urine for albumin. Please keep checking other lipids and all other things to see that the patient is going to remain healthy as a whole and not only keep his sugar normal. So this is the most important thing, prevent complications and optimize the quality of life. So you have individualized HbA1c targets, you see what is the impact on his weight, because a lot of patients may actually gain weight if you start using some medicine like sulfonylureas, insulin. So you have to see that they don't gain too much weight. Or the other way around, you give metformin, patient keeps on losing a lot of weight. So you have to optimize the weight also. You have to see what is the side effect profile of the medication. You have to choose a regimen which is easy for the patient to take, which is light on his pocket, okay, lot of things. So it has to be a shared decision to make a management plan which involves most of patients, as you see nowadays, are educated. So you have to actually involve his family also, tell them that he has diabetes, so you need to be careful about such things. Normally patient tends to be a little careless because too many things are told to him. So it is best to involve the family, tell him, see, he has diabetes, so you have to actually motivate him to do certain things. You see the patient preferences. A patient who is staying in North India, you can't tell him, go and have idli sambar, he's not going to have it. So you have to see what is the patient preferences, what he likes to eat. Okay, so all these things you have to see, and motivational interviewing, goal setting, shared decisions, and ensure that he has access to all the facilities. Alright, so these, in short, what happened in 2019, a lot of changes have been made to look at the holistic view of diabetes, not to look at just a simple view which we used to have. What is diabetes? It's sugar. What do you look at? You look at sugar, HbA1c. No, things have changed to look at a lot of new things that are coming up on the horizon. So what do we do is we are just going to look at two very new things which I am just going to introduce to you. Why? Because as practitioners, you come across a lot of patients now with so much of movement. You get people coming from abroad, people coming from all areas, and they will be carrying a lot of fancy insulins. So you want to know what is this fancy insulin that he is carrying? Because the most important thing is the patient comes to you and you don't even know what it is. I think that doesn't carry a good impression for any of us. So at least you should know that these things are available now. So we go to what is called as an ultra-fast acting insulin. Now first we have to see why is it required to have an ultra-fast acting insulin. So what we see is curved mealtime spikes with ultra-fast acting insulin. We look at it as a shift in the pharmacology and as understanding what is the intricacies. What actually happens is, when we all know that what is the fast-acting insulin, everybody say Actrapid. Okay. How do you take Actrapid? You take it half an hour before a meal. How can you take it half an hour before a meal? Very difficult. Everybody is looking at his watch. Okay. Insulin dila, other so most difficult thing. You have to go for lunch and you are working in office and you have to take your insulin. Big problem. Because how are you going to take your insulin? Half an hour before, you have to go to the washroom, take an insulin, then half an hour, you are in a meeting, you are stuck, then you go to hypo. So all these difficulties are what motivated the pharma, basically Novo. You see, Novo has been at the forefront of producing all these insulin. What we know as the Novo Rapid, the Actrapid, have all been Novo's creations. And Novo is constantly improving on itself. So it has come with a new thing called the ultra-fast acting insulin, which we will see in the next few slides. Okay? So what happens is whenever we eat, you know the glucose is going to go up. So it's a part of a normal physiology. You eat, your sugar goes up, then it comes down, then it goes up. So this is all known to us. Okay? and are they harmful to have longer excursion? That is, you have postprandial sugar going high for about 4-5 hours. Is it harmful? So it is definitely harmful. So if you see, if you have these peaks going right up and remaining for long, definitely in the long term, they are going to be harmful. So what has happened is this ultra fast acting insulin, something that Novo has developed. We come to what it is actually. Okay. So what are the possible implications of having a very poor PPG control? There is increased risk of retinopathy. You see, these are very, very important. Why I am emphasizing on these things is, a lot of time we just tell the diabetic patient, "Mari, sugar barabar hai, just jawal hai, kai karno ko," and next day he lands with an iPhone. You see, you have to imagine that a retinopathy is a really lifelong disease. You see, something that is almost to the tune of being incurable. Okay, so if you know anybody near to you who has unfortunately gone into it and got to retinopathy and is going to lose his vision, is going to lose his job, it's such a big thing. So that is why I'm saying, emphasizing that diabetes, please don't look at it as a simple sugar problem. It's much more than a simple sugar problem. Okay, there is increased catheter intima media thickness. What is this going to cause? Reduced blood flow to the brain. All other problems related to that, including strokes. It's an independent risk factor for all macrovascular disease. We know that diabetes now looks like coronary syndrome. It's almost like having a heart problem. So decreased myocardial blood flow, blood volume and blood flow are also consequences of poor glucose control. Oxidative stress, inflammation, endothelial dysfunction, all leading to future complications, including the nephropathy. So now this is just something to just show you quickly what it is. What the postprandial hyperglycemia does is that it increases the free fatty acids, the triglycerides, it increases the oxidative stress and reduces the vascular motor function and increases the endothelial permeability, which can result in further the nephropathy and all the other complications. So there was a study called a DECODE study which looked at the hazard ratio for all-cause mortality in patients not known to have diabetes and looked at what the high sugar was causing. So the implications of the 2R PPG study were seen and the 1R PPG was seen, and it was found that 1R PPG was a more stronger predictor of developing type 2 DM as compared to the 2R PPG. So endothelial function always was at 1R. So these are all studies. Okay, these are things that the people have found out and we have to go by them because it's a body of scientific evidence and we cannot deny it. So why 1R postprandial hyperglycemia might be dangerous? There are possible mechanisms. They are not proved. There are possible mechanisms. They increase the arterial stiffness, increase LV mass, increase LV gastric dysfunction, and higher triglycerides also, which further increase the complications. So what are the recommendations? So again, there are always, as you know, there is a lot of, whenever an important problem is there is difference of opinion. Okay? So what happens is when you disagree, you form a committee. So like that, we have 4 or 5 associations of diabetes. We have the American Diabetes Association and the European one, which say PPG should be less than 180. The International Diabetes Federation says nothing. It's neutral. The American Association of Clinical Endocrinologists, they say less than 140. The Canadian Diabetes Association less than 180. So if you see, this is all a confusion. Okay? So everybody says that you look at time, ADA says 1 to 2, IDF says 1 to 2, and the ACE says and CDA says 2. So there is a lot of confusion, but whatever it is, at the end of the day, I think you can look at 1R PPG also as something that is important. So Indian food, as you know, is full of carbohydrates. So you know that the highest surge occurs between 30 minutes and 1 hour, which is why probably in India it is probably important in some patients to look at what is the 1 hour PP. You know, sometimes you feel, why are you looking at 1 hour? Okay, so maybe in a patient who has, nowadays you are getting patients who are diabetic at let's say age of 30, 32. These are patients whom you need to look at early, because if they start developing heart disease by the age of 35 and nephropathy at the age of 40, it's going to be a disaster. So you have to, these patients, you have to individualize, you have to look at them early, start looking at all their parameters. So the thing has evolved from what is called as rapid insulin to the rapid acting insulin, which is Novorapid, to now the ultra fast acting insulins. Okay, so this is how it works. All right. So if you see the dotted light, dark blue line, it is the one with the normal regular insulin. The pink line. Whereas the rapid acting insulin is the blue line and the ultra fast is white. What we're trying to do is to control the postprandial hyperglycemia as quickly as possible. So that is the basic idea. The basic idea is to bring the sugar down to normal as quickly as possible, because as we see, 1 hour the same sugar values are very important for preventing further complications. Now the critical development is just something that, it's just something scientific that we just look at how we came to all these things. So these are studies which are done, and the analysis shows that the fast-acting insulin definitely has an advantage over the regular insulin. Twice as fast, which appears in the bloodstream and has more insulin at the first 30 minutes, so brings down the sugar quickly. Okay, the area under the curve also is much better. So these are all just trials which I want to show you, and these all show that the greater insulin exposure consistently were observed the fast-acting insulin as part in elderly, adolescents, children. See, it is so advantageous in these people because these are the classes of people where there is most difficulty in giving insulin, because in children you can't tell them to wait half an hour before having food. Impossible. Adolescents always on the move. You can't tell them. Elderly, they're always hungry, so you can't tell them to wait. And who is going to give it to them? So all these are the usual problems. So that is why this is most important in these patients, I think, and that is what we need to know. We are going to see much more of these insulins in the future. So I'm just introducing you to them. Okay? Because the Actrapid, Novorapid has been around for some time. I think everybody is used to them now. So these are the new ones that have hit the market, and I think it's going to do well in the future. So the pharmacokinetics and the pharmacodynamics of these also was favorable for the fast-acting insulin. So it was twice as fast and had twofold greater earlier insulin exposure. It had greater insulin action and retained all these findings. Okay? So this is the rationale of using this insulin. It has been rationally designed and has to increase absorption rate and approaches the physiological insulin. And the pharmacokinetic and dynamic studies demonstrate that it is better. Okay? So overview is that in both type 1 diabetes and type 2 diabetes, it has definitely beneficial effects. Okay? So bench to bedside, with the promise of 74% greater early glucose lowering, transfer into superior PG control, the answer is yes. Okay? So now we'll actually go for the paucity of time. We'll just go into something that has actually also come as something new. Okay? So this is something about the new injection which is available now, which is actually a combination of two insulins. One is a long-acting insulin, one is short-acting insulin. We all know mixed start. We also know mixed start 30-70, 50-50 and whatever. But this is something that balances the postprandial and fasting glucose in a new way. So this is a co-formulation concept which we have. So it was found that with the IDEC as, which is now the Novo has introduced, is something called Rhizodec. Why I'm telling you is now, more and more in future, you'll have patients coming with all these injections to you. For family physicians, they'll come to you saying, hey, insulin there. Insulin there means you should know what is this insulin. Okay? So this is why I'm introducing you to that. You have already been over the years used to give mixed start and all these things. Patients come with Lantus. So these are old things. So these are the new things that are in the market. So that is why we are introducing you to something called Rhizodec. Okay? So Rhizodec is something that is a combination of a long-acting insulin and a short-acting insulin in a way that it acts synergistically. What happens with the big start is one acts after the other. Here it acts synergistically. That's why it acts better. So that is what it is. So if you see the studies also, they have all proved that definitely the IDEC act was better than the eyeglass. Okay? So the co-formulation, if you see, this is what they want you to show actually. that both the long-acting and the short-acting, they exist synergistically. If you see with the other one, the mixed start, they are not synergistic. They are separate molecules. Why? Because the pH is different. In this, they coexist. Okay, which makes the control better and which makes the results also much more better than the other one. Okay. For want of time, because I've already seen that the bell has gone once. I don't want to push it too much. So the only thing is once daily, non-inferior to basal plus therapy. Basal plus therapy is basically giving one injection in the morning called a Lantus and then giving 3 injections. Now this is the once daily. So definitely it's better, and it is proved in a lot of studies which have been done, and there are some ongoing studies also which show that definitely it is much better. So to titrate is easy, to start is easy, and you can stay with it. The important thing is it is available in a pen. It's very easy to take. Single injection in the day. The best way to treat these patients is give 1 injection of IDFF in the morning and titrate with your oral hypoglycemics for the dinner or for the lunch if you want. Whereas with the old IGLAR, you have to give 3 injections plus 1, so 4 injections. Okay? So this is just something that is going to help you probably sometimes in trying to titrate the patient. So you go 2 units and all that. So in summary, the IDFF is a novel formulation of the degludec and the aspart, where the individual components retain their pharmacokinetics and dynamics, which is very important. You see, the mixed start, they don't maintain that, which is why these are much better. So you need a lower dose, much lower dose. Of course, they are really costly now, but I think as the use increases, they become much more cheaper. And I think in future we'll see only these injections, probably the FIAS, which is the fastest acting insulin, and the second one is the Rizodec. These are going to rule the market. Okay? Why? Because they are simpler to take. You don't have to worry about when are you going to take the injection. The ideal aspect you can take almost with the meal. So that's very easy. You don't have to think that I have to wait half an hour. You just shoot and start your food. The same thing with the Rizodec. The Rizodec you can just take about 5 minutes before eating. Mixed start you take half an hour before eating. So many advantages you have with these new insulin. They are much easier to use, and nowadays with cost not becoming a very, very big factor, I think these are going to be something that we are going to see in the future. So thank you so much for patient hearing. If you have any questions, I'll be happy to answer. Yeah.
Hi, myself Dr. Potek. I'm an orthopedic surgeon, so this was like a layman listening to you. A very, very good presentation. Very good slide about the overall approach to a diabetic patient that you showed. I come across many diabetic patients, they ask me, Doctor, आम्ही 5 वेळा खाऊ का आम्ही 2 वेळाच खाऊ? Alright, so many diabetologists say की थोडं खा आणि 4 वेळा खा, 5 वेळा खा. Now Dikshit has market disruption केल्यासारखं केलेलं आहे त्याने. He is a disruptor. So no, the thing is, see, what we follow, should we, is there a scientific basis to what he is saying? Because you also showed every time you eat, your sugar levels go up.
Like I showed you in the gestational diabetes, there are so many things that come up every year. As you see, there are 4 associations or 5 associations of diabetes. The Canadian, the American Association of Clinical Endocrinology, the American Diabetes, the European, and the IDF. So all, they agree to disagree. Okay? So this is the big thing. The same thing has come in diet. Okay? From Rujuta Divekar used to say it 5 times a day, now we are to Dikshit. Now Dikshit says twice a day. So that is the recent trend. I find most patients come to say, I'm Dikshit diet karta. So is Dikshit diet good? See, it's very debatable if you ask me. See, most of us, we go to work, and as you know, work is now long hours, you know. There is no 9 to 5 job anywhere, okay. So sometimes I tend to agree that you probably eat in the morning and sometimes in the evening, okay. And I have probably something little in between is probably the best way. It also goes with the medicines. As you know, compliance to treatment is a big issue. So for most patients, you like to give a tablet in the morning at breakfast and 1 at dinner. So if you see that way also, probably having the meal at that time and at dinner is probably physiological, probably. Because as I showed you with the insulin, what you want to avoid is the postprandial surge. So if you are having all your tablets in the morning and your meal in the morning, you are avoiding that postprandial surge. Same thing at dinner. So probably it is physiological. And eating 5 times a day, although it might look easy, I think it's quite difficult for any of us. I mean, even people who are sitting at home, eat 5 times a day, I mean, it tends to get quite boring. So I think more and more that we are seeing diabetes starting at young age. People who are working, people who are traveling, people who are meeting, long meeting. I think it probably makes sense, something like Dikshit is generally, I think, going to be the future. Because the other benefit with Dikshit diet is that I've seen a lot of patients say they're losing weight. Okay, a lot of my patients say they've lost 3 kg, 4 kg in 2 months, which is a big thing.
Exactly, junk eating also goes down. Because when you're
Exactly. So I think let the chair answer, what do they think?
Thank you very much, sir. It was an excellent session, and covering diabetes in only half an hour is a really big job. So round of applause for him. He has done great job. I have few questions beyond audience. We are always confused in pre-diabetic condition.
Yes.
And we keep on hearing word impaired glucose tolerance. So is there a difference or both are the same?
Well, actually, yes. Impaired glucose tolerance is probably pre-diabetes a new word for impaired glucose tolerance. That's what I would feel, because previously we used to call IGTT probably between 140, 199. So it's probably just a new word because IGTT is now not in the picture at all. It's pre-diabetes. So impaired glucose tolerance could sometimes go to a stress diabetes, come back to an impaired glucose. So it's probably pre-diabetes, something when you're in a stage where probably later you're going to get diabetes. Impaired glucose tolerance is something that you have, and with stress you might go into diabetes and come back. Okay, so ADA definitely is very, actually confused, and it's not mentioned anything on that. I've gone through that, and I haven't shown anything on IGTT at all.
You discussed about the use of metformin post-pregnancy. If a patient is already on metformin for infertility, I see a lot of patients are on metformin for infertility.
Yeah.
And once the patient is conceived, so what we should do? We should stop it. We should go ahead.
I think most of the patients we do continue the metformin. Okay, there is no reason to stop the metformin. If the patient's sugar are very uncontrolled, you add insulin. But there is no reason to stop the metformin. I don't think that there is recommendation. Although even now with ADA 2019, there is no clear, let's say, indication to use metformin. They do not say that you should use metformin. But as clinicians and as gynecologists, all of us use, and we have not found any complications as of now. But there is no recommendation, definitely.
Is there any other drug which we can use for the hypoglycemic?
In pregnancy?
Yeah.
Yeah. See, glyburide has been used. Okay, glyburide has been used, and we know that 4-5 years back, or maybe 6 years back, we all learned that glyburide plus metformin is used. Sulfonylurea, people are worried about hypoglycemia. So only very short-acting sulfonylurea are allowed, not recommended. Yeah.
Regarding HbA1c, what target HbA1c we should actually aim for? Is it same for all the patients, or we should differ for different patients, like old age and...
Yeah, that's a very good question. Actually, see, the HbA1c target is below 7. That's what Indians and Europeans follow. Americans have come to 8. I don't think 8 looks very good. 7 is what we should look at during treatment. So between 6 and 7 should be what we try to maintain. If you're going below 6, maybe you're actually possibly going to hypo, so maybe you can reduce it. But possibly maintain it under 7, number one. Secondly, with elderly, we are a little more relaxed. Probably 7.5, I don't know. What Abhijit, what do you feel? Abhijit is a diabetologist among us, so he can answer better. What do you think of elderly? What should we use? 7.5?
Sir, we are using the non-hypoglycemic drugs like gliptins and all.
That is the best.
We can get the HbA1c 7, that is okay. Otherwise,
Yeah.
the elderly
What
also
would you target HbA1c?
the couple that all the children are gone to USA. Better to keep them around 7.5.
7.5. Around that. Yeah.
A few questions about insulin.
Yeah.
You were talking about if someone comes from abroad and comes with some fancy insulin. So how do we differentiate in insulins? Is there any international color coding for that?
Yeah, as you know, most of the color coding was accepted, as you know, for the formulation that yellow generally would be something that goes with the regular insulin. The brown would go with the mixed combination. And the Iglar and all carry those purple kind of colors. But most of the times, if the patient has brought the thing to you, it will be mentioned on that what it is. So that's what I'm saying. So most of the time, Aspart, Novorapid, they are all fast-acting insulins. Anti-IDEC aspart you are having, anti-active. Okay. The other combination, Iglar is Glargine. Glargine is a basal insulin. So Glargine is a basal insulin. And the mixture, of course, comes in 30-70 and the 50-50.
Even if we see the color,
yeah, so generally if you have somebody that gets a vial with yellow color, it's always a regular. Okay, you have somebody coming with a brown band around it, it is the mixed start.
There is one insulin we have just heard that it can be taken at any time, not
yes.
exactly 24 hours. If I miss a dose, I can take it after 6 hours.
Yes.
Just talk about that later.
Yeah, these are exactly the newer insulins like the IDEC and all, which can be taken absolutely any time, and you don't require. You know why? Because the closer you are to the insulin surge, I mean how quickly your insulin enters the circulation and how quickly it's acting is what actually determines for you how, what is when you can take the insulin. Okay, so some of these insulins which are long acting, like the IDEC or the Tresiba, you can actually take them after the food also. So it doesn't matter because they are all long acting. Whereas something like the IDEC you can almost take with the meal because it's going to act within about 15 minutes. So it's going to bring the post-prandial surge down very quickly. So that's it.
The last question. There are a lot of people in the market, they claim they can cure diabetes. What is your take on that?
See, now curing diabetes I think is a little far-fetched, but controlling diabetes, yes. Now, I personally have a lot of patients who are only now on diet control after being on almost 3 to 4 OHs. Okay? So if you look at good lifestyle modification and exercise, as you know for diabetes, we always look at first lifestyle modification, exercise, and last resort of the drug. So there are a lot of people whom the diabetes can be controlled. Now, whether the diabetes can be cured, we don't know. Now, all those patients, a lot of patients who undergo bariatric surgery, probably, in those patients you could talk of cure. Okay, those who lost significant amount of weight are probably cured. I mean, that is where you could say that, okay, they are cured of diabetes. But otherwise, I think control, yes, control is very much possible without drugs. But cure, I think, probably bariatric.
Thank you very much, sir.
Thank you, sir, for helping us about diabetes. It is very, very prevalent these days. I would request Dr. Rajendra Joshi, sir, to please felicitate Dr. Shivram Bhonagiri. And I would request Dr. Purushottam Joglekar, sir, to please felicitate chairpersons. Dr. Joglekar, please. Dr. Rajendra Joshi, sir, and Dr. Dinesh Lokhande, sir. I know we all are hungry, but a big round of applause for such a prevalent topic.